So EGFR mutations, I think that field is pretty much solidified in the sense that osimertinib, the third generation inhibitor, is your go-to initial choice for somebody with an activating EGFR mutation. I think you can line up and you say the median progression-free survival looks very similar to if you gave sequential therapy. You know, you can do the clever algebra and you can say, I go to first generation drug, 60% get T790M, and I add together, 60% of the PFS for that, and 40% will get chemo and add together that, and it comes out about the same. But if you try and explain that to a patient, they look at you as if you're crazy. They go, well, I don't care about your algebra. Why don't you just put me on one drug and then you don't have to change it? And I think that solidified that. And so it opens up the idea as to where do we go next. People are looking at, adding in anti-angiogenics to osimertinib. People are probably looking into adding in chemotherapy to osimertinib. Although those are both hard sells. You have a pill that's going to control your disease for potentially a number of years in some cases. You really want a short leash to the infusion center, so those are hard sells. Perhaps the area that's looking even more interesting is trying to understand how do people eventually progress on osimertinib, and then what become rational combinations. And rational combinations, I think the challenge there is if you try and do them all up front, maybe a rational combination only applies to a certain subpopulation, and if it's only like 5 or 10% of those people, maybe doing it in everybody up front isn't going to make a difference. Maybe we are going to have to, subdivide a pie chart of mechanisms of resistance, and then each will go down a different path.